nutrition, and she even finds the time to go to the spa. She has been an inspiration to all of us who have been lucky enough to be her colleague, her mentee, and her friend. Today, she will talk to us about cardiac disease in women, emerging risk factors. Dipti?
Hi, Dipti.
You're muted.
Can you hear me?
Could you see my screen earlier when I was bringing it up?
Not yet, no. I made you a co-host.
Let me do that. Okay, let me share my, okay.
Now we got it. I think we're
There we go.
awesome.
Okay, perfect. Thank you so much for that introduction. And it's nice to see familiar friends, and I'm so happy to be here. Thank you for the invitation. I want to say hello to Joe Marine also, and thanks for joining, Joe. So I wanted to talk about cardiac care in women, sort of this emerging risk factors. This was a topic that I sort of got interested in several years ago, because we talk a lot about women and heart disease, but you know, there's a lot of data out there. And as I got into it, I started to think about this idea of things that we didn't know. So I have no disclosures. I mean, we know that heart disease is a leading cause of death for women in the United States, as it is for men. But we know that for the past 3 decades, we've really had some declines in heart disease mortality, not in the total prevalence. We know that that heart disease is increasing worldwide, but in terms of heart disease mortality, we've seen a decrease, particularly in older women. And why is that? Well, there's many reasons for the progress. One is that we just have a better understanding of the sex differences, right? And this has implications for diagnosis, treatment, and outcomes. So we recognize now that women are more likely to have plaque erosion rather than rupture. We know that they tend to have more thrombus formation. We also understand that they have more outward or positive remodeling. And so with plaque erosion, we see this if you were to do IVUS, and about 1/3 of the women that have acute coronary syndrome and have no angiographic lesions, we see this plaque erosion. And we know that this is a result of endothelial dysfunction, some leukocyte activation, probably some inflammatory component also. This also might be related to coronary vasospasm, which we know can be related to myocardial infarctions, particularly in women. What about positive remodeling? We know that this focus on sex differences has led to this identification of sex-specific mechanisms, namely myocardial infarction, without this apparent epicardial stenosis or thrombus. And so we know about that. We know that we have this recognition of these entities that are specifically related, that we see specifically in women: spontaneous coronary artery dissection and Takotsubo's. Why? Because women have more endothelial dysfunction. And that these risk factors like hypertension, dyslipidemia, diabetes lead to the endothelial dysfunction, cause a decrease in the nitric oxide synthesis, increase inflammatory, increase endothelium, and then this then is associated with this increased coronary events. So SCAD, just briefly, just so you know, that's non-traumatic, non-iatrogenic, non-atherosclerotic separation of the coronary arterial wall, right? And it's usually by intramural hemorrhage. SCAD causes anywhere from 2 to 4% of acute coronary syndrome patients and accounts for, you know, about 0.5% of sudden cardiac deaths in women. And 35% of myocardial infarctions are women under the age of 50. 43% of the pregnancy-related myocardial infarction are because of SCAD. So again, some of this understanding of the mechanisms has helped us to understand this. So we realized, when we always traditionally thought, well, young women were not affected, well, we recognize that even young women can have heart disease. And so in young women less than 60 years of age, SCAD accounts for about 22 to 35% of acute coronary syndrome presentations. And interestingly, the most common precipitating factor was emotional stress in almost about 30% of the patients. What about Takotsubo's? Because I mentioned that for women. Again, known as that broken heart syndrome, right? And it's more encountered in older postmenopausal women. And women have almost 9-fold higher risk compared to men. Interestingly, if you look at the data, Takotsubo's has increased over 19 times if you look at 2006 all the way to 2012. And this just may be that we have enhanced awareness and recognition of that clinical profile. And then again, most of it, but definitely not, is from lifetime stressors, right? But if you look at this, it's not just emotional stress, it can be physical stress, and then risk factors can contribute to that. Again, this whole issue of endothelial dysfunction can cause the stress cardiomyopathy. Now, I bring all that up, but really, you know, what I want to try to get to is the point of talking about these risk factors and what have we learned in the last decade. But one of the things that I want to start off with is to say that, you know, we've known about women and heart disease, right? We know that even young women have heart disease, and we've tried to create awareness programs. So the Women Heart Coalition, Go Red for Women. But it's interesting that despite increasing all of this awareness over the past decades, only about 56% of women recognize that heart disease is their #1 killer. So we know that there's still room here to educate the women. And this is going to be important as we talk about risk factors, because we can identify the risk factors, but we need our patients to also have increased awareness if we're really going to make a headway with this. And a study that was done by Noel Mariurs at Cedars, you know, this was in 2017, a survey of American physicians said that less than half the cardiologists believed that they were extremely well prepared to assess cardiovascular disease risk in women, hence this talk. And this rate really fell down to 22% amongst primary care physicians. And interestingly, and this is an important one, cardiovascular disease was rated as a top concern by only 39% of PCPs. And you know why I think this is interesting? The last, in your talk that's coming up next month with Martha Galati, the ACC has come up with what they call the NCD, and it's an app. And really, it's made for internists and the cardiovascular team members, and it's a whole education curriculum for them to better do a job in terms of identifying cardiovascular risk factors and help in terms of cardiovascular disease. And when you go to internists and say, hey, listen, you've got this NCD, you can put it on your phone, you can learn. They said, well, you think the only thing I do is cardiovascular disease? I know you're a cardiologist, but you just think it's all about cardiovascular disease. You know, I have all these other things that I take care of. I have to screen for cancer. I have to make sure they're vaccinated. I have to make sure that they're not osteoporotic, you know. So there's other issues. But so again, when we think it's all about the heart and cardiac risk factors, they don't see it that way. So in spite of the decline for cardiovascular disease over the recent years, we see an increased mortality in younger women, and this is very important. I mentioned to you that we've seen a progress in older women, but in younger women, less than 55 years of age, and this was borne out even in the Virgo trial, and I'll come to that in a few minutes. And why is this? It's because there's this increased recognition that, you know, we have the prevalence. There's an increased prevalence of traditional cardiovascular risk factors, but and they have a differential impact on women, and we'll touch on that. But there's also this emerging non-traditional risk factors, more unique and more common to women. And I think that is important for us to understand and hopefully start to target those so that we can have some improvement even in that younger age group. So I just bring this up because myocardial infarction in young women, they say that maybe that's a distinct entity. And we know that that incidence of acute myocardial infarction in younger women is increasing. They've done the Virgo trial, which is a variation in recovery role of gender on outcomes of young AMI patients, the so-called Virgo study. One of the things that it revealed was that there's a high degree of comorbidities, cardiovascular risk factor burden in these people that ended up having the acute myocardial infarction. And interestingly, if you look at risk factors, it talks about traditional and non-traditional, and that's what we're going to talk about. An adverse pregnancy outcome. We're going to talk a little bit about that. The other interesting thing is that a lot of times we classify women when they come in, particularly young women, as atypical chest pain. And sometimes that causes delay in diagnosis, under treatment, and worse outcomes. So I think we have to be a little bit cautious with that. So this is some of the stuff that we're going to touch on. So traditional risk factors on this side, diabetes, we're all well aware of this, smoking, obesity, being overweight, physical inactivity, hypertension, dyslipidemia. We know about this. In fact, the AHA update, the 2021 update on heart disease and stroke statistics was published earlier this year in Circulation. And they talk about all of these things. And one of the things they noted is that we see an increase in heart disease prevalence. And why? It's because we're not really making good headway with regards to diabetes and smoking. The only one that we really made a headway was a little bit was hypertension. And we did that even in all ethnic and racial groups except for Black women, where we didn't make as much of progress. So our educational endeavors helped in the hypertension arena, but somehow we're not making as good of strides in terms of diabetes and smoking. And one of the things that really struck me in that data was the amount of e-cigarette smoking that had increased tremendously, particularly in our adolescents. And I think that that's really important. We've had a couple pieces of legislation that have come out over the last couple of years to help target that. And so hopefully that's going to make a difference. But let's talk about the non-traditional risks. And we're going to spend a lot of time during this talk really talking about this. Preterm delivery, hypertensive disorders of pregnancy, gestational diabetes, autoimmune disease, breast cancer treatment, the sort of emergence of cardio-oncology, and depression. These are the ones that I really want to target and I'm going to talk more in depth about. So I like this slide. It gives us the same information sort of flipped over. But when you look at this, if you have lupus, you have a 3-fold higher risk of ischemic heart disease events. And rheumatoid arthritis elevates the ischemic heart disease risk as much as diabetes. So we all know about diabetes, but do we think about that every time we see a rheumatoid arthritis patient? I don't think so. Diabetes, if you have gestational diabetes, you have a 4-fold higher risk of developing long-term diabetes and 59% higher risk of myocardial infarction. What about hypertension in pregnancy? Again, we're going to talk a little bit more in detail, but gestational hypertension and preeclampsia, we're going to talk about that. Early menopause confers the higher risk, and then depression almost doubles the risk. And I think these are things that we don't talk about commonly. I think everything in the blue arc we do, but these are the ones that are sort of the emerging risk factors. So let's talk briefly about the traditional risk factors, right? 13.4 million women have diabetes, and 90 to 95% of this is type 2. The relative risk for cardiovascular disease is 44% greater in women with diabetes than men that are diabetic. And you have a 3-fold excess fatal coronary artery disease risk in women that have type 2 diabetes compared to non-diabetic women. So again, if you're a diabetic woman, higher risk than a man, and higher risk than a non-diabetic woman. And what about cigarette smoking? Well, 25% increased risk of coronary artery disease with cigarette smoking. And one of the things that we've noticed is that as men have smoked less, women have smoked more. I mean, this has been part of the sort of women's liberation. Unfortunately, we're killing ourselves with this. And so cigarette smoking, and particularly important to get this message to our younger women, and especially the ones that are using birth control pills, cigarette smoking with that really increases that risk. What about this obesity issue? This came up in the paper I was talking about. Again, more than 2 in 3 adults in the United States are considered overweight or obese. And the prevalence of obesity is certainly higher in women, so that confers a higher cardiovascular risk. In terms of hypertension, again, when you go between the age of 65 to 74, 69% of women have hypertension. Over the age of 75, 79% of women have hypertension. Very important, it increases their risk. Dyslipidemia, we all know about that, also increases the overall risk. And so these are things that we obviously need to target. But these are some of the emerging, and we talked about this in that previous slide, but I just want to lump it so it's easier for you to remember. Pregnancy-related complications, autoimmune diseases, sort of the postmenopausal state, premature menopause, hormone, and also surgical, if they've had a hysterectomy at an early age without, a complete hysterectomy without replacement. Hormonal status, if they have polycystic ovarian syndrome, and then certainly cancer treatment. So I think these are the things that we're going to talk about. And remember, when they did that, when we have had our prevention guidelines, we talk about what are the risk enhancers. And chronic inflammatory conditions such as psoriasis, rheumatoid arthritis were considered risk enhancers. And then also they mentioned the history of premature menopause or pregnancy-related conditions. So we do need to keep these in mind. So it says menopause, the symptoms are real, man. And the doctor says, I'll have to run a few tests to be sure. I'm guessing it's either hot flashes or global warming. So when it comes to women-specific risk factors, obviously this role of pregnancy and cardiovascular disease is coming up. we're going to see a lot more of cardio obstetrics. I mean, Jack just had a huge issue that was released specifically talking about that. There have been many studies that have looked at this association of gestational hypertension, preeclampsia, gestational diabetes with cardiovascular disease risk. And we need to really start to catalog some of this, because we know that 10 to 20% of women have adverse pregnancy complications. So the ones we're going to really look at is the ones on over here: gestational diabetes, hypertension, preeclampsia, and preterm labor. So what about gestational diabetes? Well, we know that this is newly diagnosed diabetes beyond the first trimester of pregnancy. And we know that if you have a history of gestational diabetes, you have cardiovascular disease events 7 years earlier than a non-gestational diabetic female. We know that there's a 4 to 7-fold increase in the risk of developing type 2 diabetes later. So these are patients that should be flagged for us to have a lower threshold to monitor them and treat them. Again, compared to a non-diabetic woman, diabetic women have a 3 to 7-fold increase of cardiovascular disease risk compared to a diabetic man. So we know that this is really important. And in general, if you had gestational diabetes, you're more likely to have a risk of myocardial infarction, 59%. That's a higher risk. What about gestational hypertension? Again, it complicates about 5 to 10% of pregnancies worldwide. And most of these are gestational hypertension and preeclampsia. What is the definition of gestational hypertension? Well, this is new onset hypertension after 20 weeks of gestation in a woman who was previously normotensive. And interestingly, there have been a meta-analysis of 9 studies, and gestational hypertension was associated with 67% higher risk of subsequent cardiovascular disease. So we have to take this seriously. And most of these patients have a higher BMI and a history of hyperlipidemia. So a lot of these patients have these risk factors that were present prior to pregnancy. They develop this complications and then go on to become cardiac patients. So preeclampsia, what's the definition of that? Again, new onset hypertension after 20 weeks of gestation, as well as proteinuria and end organ dysfunction. The prevalence is about 3 to 5%. Worldwide, it's a little bit higher. In developing countries, as high as 14%. And it also is associated with approximately 25% of the preterm births. And so, worldwide, preeclampsia and eclampsia are responsible for approximately 14% of maternal deaths per year. And interestingly, in the heart disease and stroke statistics that were published earlier this year, for the first time, they included pregnancy-related complications in the data that they're following for that. And it was mentioned in that paper, and I've heard this before, that it turns out that cardiovascular disease is the #1 reason for mortality, maternal mortality in the United States. So it's just something for us to keep in mind. What are the long-term consequences of preeclampsia? Well, a 4-fold higher incidence of hypertension, 3-fold higher incidence of type 2 diabetes, 2-fold elevated risk of cardiovascular death. So, and then remember, a preterm, preeclamptic woman is at the highest risk, and you really have to watch those women. In fact, I saw a patient like that today who had had a preterm delivery. She had preeclampsia, and she came in to see me, and so I had to keep really. And I told her, I said, look, you're going to be a high-risk patient, and you're going to be somebody that needs to be watched for a long time. Interestingly, the risk of cardiovascular disease is higher in women exposed to early preeclampsia than if they were diagnosed with preeclampsia later in pregnancy. So even within preeclampsia, early, they're at higher risk. Later, they're at higher risk, but not as high as if they came in early. And then again, severity of preeclampsia is correlated with the severe of cardiovascular disease later. So the worse preeclampsia is, the worse their cardiovascular disease risk. And so I sort of put the criteria here. What is preeclampsia? And then what does it mean to say you have severe features? Well, they have pulmonary edema. They can get impaired liver function. And they tend to have thrombocytopenia, progressive renal insufficiency. So, and these are the ones that sometimes can have that new onset cerebral visual disturbances. So keep that in mind. Those are patients with severe preeclampsia, usually the ones that need to get delivered quickly if they can. Now, what about recurrence? Well, once a patient's had preeclampsia, the recurrence rate is normally around 16% on the average. Women with early onset severe preeclampsia are at the greatest risk of recurrence, as high as almost 65%. And most of these patients, if they have that history, have low dose aspirin during their pregnancy to reduce the risk of preeclampsia. What about preterm delivery? What does that mean? So that's if you deliver earlier than 37 weeks, about 6 to 12% of deliveries in the developed world. The risk of atherosclerotic cardiovascular disease was further increased with a history of early preterm delivery, and I mentioned that earlier. So again, women who deliver a preterm infant are at 40% increased risk of future cardiovascular events, but those who deliver, prior to 32 weeks experience a doubling. So again, that's important to remember earlier, the worse it is. What about autoimmune disease? Well, we know that the female to male ratio for rheumatoid arthritis is 2.1 to 1, and lupus 9 to 1, the ratio. So of course, you're going to see more women with these autoimmune diseases. Women with rheumatoid arthritis have 2 to 3-fold higher risk of myocardial infarction and 50% higher risk of a stroke. Lupus patients, the risk of myocardial infarction can go up as high as 50-fold compared to the general population. Interestingly, cardiovascular risk scoring systems underestimate the burden of these cardiovascular risk in patients with rheumatoid arthritis and lupus. Remember, these were categorized as risk enhancers. That's why I think doing just a simple scoring mechanism in our female patients, sometimes we underestimate their burden of cardiovascular risk. I want to go talk a little bit about cardio-oncology. We know that cancer therapy has obviously been more effective than ever before. Cancer survivorship has tripled. I know this is slightly older data, but in 30 years from 1970 to 2000, we saw tripling of the survival. There are more than 12 million cancer survivors in the United States. And long-term cancer survivors now represent one of the largest and fastest growing population that's at risk for premature cardiovascular disease. And in fact, they believe that the increases in cardiovascular morbidity and mortality sort of offset some of the advances we did in cancer-related survival. Now, why is that? Well, sometimes cardiovascular disease can pre-exist cancer therapy, right? Sometimes it can be caused or exacerbated by the therapy. And remember, almost all anti-neoplastic agents are associated with some degree of cardiotoxicity. I mean, we know about anthracyclines, we talk about like Herceptin and things like that, but really, they all can have some cardiotoxicity. And then if they got radiation, particularly on the left side, that can lead to, coronary artery disease and these fibrotic changes to the pericardium and myocardium. I've seen that. I had a patient that had a non-Hodgkin's lymphoma, and he had, mantle radiation at Stanford where I trained. And I saw him when he first came in. I think he was like 39 years old. He had his first myocardial infarction. He then subsequently, several years later, had a significant aortic stenosis, ultimately ended up requiring a heart transplant, but died postoperatively. So, and a lot of his problem was all because of radiation therapy. Now, I wanted to sort of hone in on the breast cancer issue. Women in the United States has 1 in 8 chance of being diagnosed with breast cancer at some point in her life, right? So this is the #1 cancer for women. Over the past few decades, the breast cancer survival has improved, right? They've reduced the death rates, and now there are almost over 3 million survivors of breast cancer. And if you're a postmenopausal woman with a hormone receptor as of HR plus breast cancer, these patients tend to have higher cardiovascular deaths, and they can tend to die from their cardiovascular death, and it increases, they exceed the cancer mortality in that group. Now, there's some increased recognition of common risk factors for breast cancer and cardiovascular disease. This is very interesting. If you have a female smoker, she's got a family history of cardiovascular disease, she's obese, and she's got a sedentary lifestyle, not only is she at higher risk for cardiovascular disease, but she's at higher risk for breast cancer. Now, the other interesting thing is that breast cancer is the most common secondary malignancy amongst women. They tend to have childhood cancer, and then some of these have already received anthracycline treatment. So what's important is that we need to pay attention to their history of prior treatment, because we want to make sure that when they get their breast cancer treatment, we're not compounding the problem in terms of the chemotherapeutic agent, and then that makes their cardiovascular disease worse. So, this is this is just a reminder that when you look at breast cancer patients, they really should be evaluated for cardiovascular disease at the get-go, at the diagnosis, at the start of treatment, during treatment, and at the end of treatment. And if you look, the second box says that protective, cardioprotective strategies, and those include beta blockers, ACE inhibitors, angiotensin receptor blockers. There's been some small studies that show that maybe those can help, but there's been nothing that has completely, obviously these are not completely protective. It's not like if you give them beta blockers and ACEs and ARBs that you can just do what you want. This is a reminder that these patients are on a continuum and that they need to be followed all the way through. Depression. I think this is a really important one because I think we don't think about this. Depression is increasingly recognized as a risk factor for development of cardiac disease. Depression affects women worldwide 2 times more than men. And they can emerge as early as adolescence, and you can see this in adolescent women. It's a significant risk factor for the development of MACE and cardiovascular mortality. And women who have experienced a cardiac-related event are more likely to be depressed than men. And I think the graphic shows that, if you're depressed, you tend to have more of the behavioral habits, right? Increased cigarette use, maybe lack of exercise, dietary things. That then can cause the physiologic mechanisms for deregulation of the autonomic nervous system, and particularly the inflammatory response. You have a huge inflammatory response that then can feed into this issue of increased cardiovascular disease risk. The last sort of thing I want to touch on is this breast arterial calcification. So this is a mammogram picture. In the first box, there's mild breast arterial calcification. The middle one is intermediate amount of calcification. And the third one, you can see almost, if this was a coronary artery, you could see the sort of outline of that coronary artery. That's how much marked calcification. And, obviously there's a little bit of a subjective interpretation, but, for a seasoned mammographer, they would recognize sort of the mild, intermediate, and marked calcification. Why is that important? Well, what we know is that with the technical advancements in mammography, about almost 13% of women undergoing breast cancer screening have some degree of breast arterial calcification noted on their mammogram. And the most important determinant of this is age, right? So as you get older, you have more breast arterial calcification. So about 10% of women in their 40s, but 50% of women in their 80s have breast arterial calcification. Interestingly, factors associated with this higher prevalence, apart from age, include diabetes, parity, chronic kidney disease, personal history of coronary artery disease, and risk equivalence. Interestingly, smoking is associated with a lower breast arterial calcification, and that's true for even coronary calcification. And I don't know the reasons for that. And they really haven't found a significant risk linked to hypertension, obesity, and others. But there's been multiple studies, including a few prospective, that have suggested a strong association between breast arterial calcification and cardiovascular disease, independent of other known cardiovascular risk factors. So, they say that when a mammogram is done, that we should look at breast arterial calcification because that may help us with some sort of cardiovascular disease risk stratification. So we're not only looking for breast cancer, but we may be able to get something where we can start to counsel our patient about lifestyle changes, and that can not only help their cardiovascular risk, but their breast cancer risk. And so I think the studies favor a correlation between breast arterial calcification and cardiovascular risk factors. And so there's some evidence that supports the universal reporting of breast arterial calcifications, and then maybe this personalized discussion to talk about aggressively treating their cardiac risk factors, and help them have a more healthier lifestyle. So I think in general, I think what I was getting at is that we need to do sort of improved cardiovascular disease screening in women. I think that we need to certainly assess them for traditional risk factors, but also these novel risk factors, and we need to be aware of that. I think, when I started talking about this, I realized, did I routinely ask my female patients about pregnancy-related complications? And I can tell you the answer was no. Do I do that now? Yes. And so you need to ask them about pregnancy-related complications. We need to do a better job of educating women even about the, heart disease symptoms, because they can have atypical symptoms. But I think we need to not see them as atypical symptoms, but recognize that they may be their way of actually really saying they have disease. Counsel them for lifestyle. I think targeting smoking, diet, physical inactivity, paying attention to their history of stress and symptoms of depression, And then I think we need to sort of think about the calculation of lifetime heart disease risk and not just look at the 10-year risk calculator and really target the risk factors if appropriate for appropriate treatment. I found this sex-specific questionnaire, and you can design something like this. I guarantee that most of us do not have something like this included in our intake for our patients, to ask them, do they have polycystic ovarian syndrome? Do they have they been pregnant? I mean, we probably ask how many pregnancies they've had, but we don't specifically ask about complications during pregnancy. Do they have any postpartum complications? Have they had miscarriages? And what age did they go through menopause? But I think this is really important information for us to get. So I think that we need to start thinking about those novel risk factors in our women. The ACC has developed some of these handouts for patients, and they have the pregnancy-related complication and heart disease risk. So this is something that we can, send our patients to if we see a pregnant woman or a woman for learning more. So CardioSmart is dialed into this so that we can do a better job of education. So I'm going to stop here, and I'd be happy to take any questions. But really, I think what I wanted you all to take away was that we need to think beyond our traditional risk factors and to really start targeting women earlier, and start to talk to our OBGYN colleagues as partners, and even our rheumatology colleagues, because I can tell you I'm seeing a lot more patients to refer to me from my rheumatology colleagues if they have lupus and rheumatoid arthritis, to sort of evaluate them for cardiac risk factors. And certainly my OBGYN colleagues are dialed into this. So I'm going to stop here and be happy to take any questions.
Thank you so much, Dipti. That was really great. I have a couple of questions, actually. I'll start off, and one observation. You sort of alluded to the fact that our current, scoring systems that we use, like the pooled cohorts equations, sort of don't or underestimate risk in patients with systemic inflammatory conditions, and they also obviously do so in those with some of the pregnancy-related complications that increase risk that you pointed out. So, one question would be, should those risk calculators be tailored more so than they are now, personalized, which is challenging because then you sort of they become more difficult to use in routine practice. But my sense is that a lot of our provider colleagues, especially in primary care, probably under recognizing this risk, as you point out. And then the second question is, in a patient like you presented with these sort of non-traditional risk factors, what is your general approach to screening them, or to risk assessing their risk, in terms of just to rely on clinical variables? Do you do any sort of further screening, like CT coronary calcium scores, CRP levels, anything like that? Thanks.
So those are great questions. So in terms of let me get to the first one, the risk assessment. I'm not sure we as cardiologists, there's been discussions about redoing that risk scoring, because even the Asian populations are under, sometimes we don't get an accurate read on that. But like you said, it becomes difficult to do that. And if you have multiple scoring methodologies, it may be difficult. I think we need to recognize that it does not give us the full picture. Now, I think that's easier for us to understand, harder for us to convey to our internal medicine colleagues that are taking care of some of these patients. So I think that one's a tough one. But I think I always tell them that you have to look beyond just a traditional risk assessment. And we need to keep those other things and really think of them as risk enhancers. And if they're sort of considered lower risk but have a lot of risk enhancers, and I sort of help say that these move the needle. So I think a lot of the education to the internal medicine colleagues would help with that. With regards to how do you assess these patients, yes, I first of all will just do a clinical evaluation of what are their traditional risk factors. What's their BMI? Are they smokers? What is their cholesterol profile? What about hypertension? I used to do a lot more. Do a lot more CT calcium scoring in some of these patients. I think that now with this breast arterial calcification, most of them have mammograms. It's kind of nice to use that. Believe it or not, there have been a couple studies that have looked at the correlation between breast arterial calcification and calcium score, and there is some correlation there. So that may be a way to go, because that's something they're doing. They don't have to go and get yet another test done. But I think the biggest thing is to just have the conversation, so they're understanding that they're at higher risk and that we need to have a lower threshold for monitoring them regularly. A lot of these patients, right, that have had pregnancy-related complications, what do? a lot of the OBGYNs are the only, that becomes their de facto primary care physicians, right? And, you know, I'm not sure that they're as dialed in sometimes to monitoring them with, you know, risk factor wise, what is their blood pressure? I tend to think a lot of them are seeing well babies, so they even blood pressures are always 120/80. I mean, you know, and so I sort of emphasize to them that some of these things are really important, and then making sure that they're screened appropriately and recognize that it's the long haul, and hopefully may help them to make some lifestyle changes early so that we can impact their long-term cardiovascular risk.
Thank you so much. One of the questions, or a couple of questions that came through the chat, had to do with the finding of breast calcification on mammography that you pointed out, and mentioned that might be a correlation with that finding of the finding of CT coronary calcium. Is calcification on mammography? Do you think that's something that might be underreported by, you know, practicing radiologists? Has that been looked at all?
Yeah, I think so. And that's why they said that they're recommending that it be routine part of the reporting, because it's sort of like data that's there, but we're not sort of reporting on it. So therefore we're not acting on it. So I agree with you that I think it is underreported, but maybe there needs to be more of that reporting. And I think that once we all get sort of educated and said, hey, we're going to start asking our radiology colleagues, hey, what was the, you know, because I do that now, and I contact my radiology colleagues, so they know that that's something that I'm interested in.
Right, and it was similar with coronary calcium on like lung cancer screening CTs. I think maybe less so now, but there was a time where I felt like that was not routinely, you know, reported, and we would review these CTs just on our own and find, you know, that present. Any other questions from any of the participants?
I have one quick question for Dr. Itechakpuri. Thank you for the excellent presentation. I have a question about the aspirin in women. Now, from the large preventive cardiology clinical trial results, we kind of took a step back, not to routinely start these women patients on aspirin because the net benefit was kind of zero. But I was thinking for the patients with preeclampsia, they were treated during pregnancy with aspirin. These people have a placental microvascular disease. Do you think later in their life, we should consider putting them on aspirin for primary prevention more aggressively than the regular woman patients?
Yeah, I mean, I think so. I think that that's not been looked at, but I think that would be an interesting thing to look at. But I agree with you. I think there's also controversy whether all the diabetic female patients should be on baby aspirin as primary prevention because they're in the high risk group. So I think that we need to look at that. But I think I agree with you. I think that certainly is interesting, and we should consider that in those patients. They're at very high risk.
Thank you.
Ryan, if I may chime in for a moment, Governor's prerogative here. First, I just want to thank Dr. Itechakpuri for a very thought-provoking and eye-opening lecture. And I don't think I could ask all the questions that's opened in my mind in the next hour, so I won't. But I think my overarching observation is that reminds me of the sheriff in the movie Cool Hand Luke. What we have here is a failure to communicate. It's a systems problem that the radiologists don't fully report the information they're seeing, but don't realize often the significance of it. The people who are delivering the women and delivering the babies and managing the pregnancies aren't concerned about the long-term consequences of what they're doing. And by the time they reach the age where they become of interest to internists and cardiologists, some of that information's been buried in the sands of time. I have a daughter who's a nurse midwife, and one of my partner's daughters is a neonatology fellow. I've asked them both what they do when they have a patient who's had preeclampsia or some of the risk factors you've identified, because the neonatologist, every single one of those mothers is at risk just because their kids are in the neonatal ICU with preterm deliveries. And they basically, they're smart women, but they say, well, what are we supposed to do with that information? Our job is to get the baby delivered, the mom healthy and home, and we're not going to be necessarily taking care of them when these problems are going to develop. It's very much like cardio-oncology. there's a lag time between the therapy and the cardiovascular complications that develop. And unless and until the cardiology community and the internal medicine community and the OB community get together and decide how we're going to manage these patients in a systematic fashion so the information is collected at the time that it occurs, but remembered as their disease processes are going to start to emerge, we may be able to intervene with preventive therapies as opposed to throwing medicine and treatments at them once they're developing, calcification of their arteries and coronary artery disease. Then we're just putting a Band-Aid on the problem with fancy stents and the like. So, we are the ACC, you are the president, we are cardiologists, and one of the charges, I think, for all of us is going to be how do we at a system level help intervene for these women so that through the course of their lives as they're raising these babies, their risk factors don't go unnoticed and uncharted. Many of the questions that you have on your patient intake form, if I were to go to our clinic and ask women those questions, they would either tell you, I don't know, no one ever told me, or I forget the answer to some of these questions. It gets buried in their memory. So it has to be picked up, and maybe with electronic health records, if we got them more useful, we could be putting this information in and carrying it forward so it doesn't get forgotten. Have you given much thought to how we address that aspect of the problem?
Well, I mean, I think it's a great, all the points you made are great. And that's why this emergence of cardio-oncology has been really helpful, because the cardio-obstetrics, you're going to see a lot more on cardio-obstetrics like we have for cardio-oncology. And I think that's what they're specifically looking at, is this approach of how do you care for these patients from the time when they get pregnant to long term. Who do you identify, and how do you care for them long term? So I think there's a lot more to come for this. But I think that the emergence of this, it's too bad that we have to have a subspecialty just to target it, But that with the emergence of cardio-obstetrics, I think we certainly have collaborated with our OBGYN colleagues, and I think that collaborative approach is what we need. And we really need to collaborate with our ACP colleagues, right? Because they're also going to be playing a role in taking care of these patients. They need to be able to get this history and dwell into the risk factors and take them seriously, rather than just saying, it's a woman and she's not at risk.
Here.
Yeah.
I think one of the approaches is what our WIC chapter is doing, which is to do more collaborative education of the population. So I'm happy that our WIC chapter is going in with our ACP chapter in the state to try to bring the internal medicine community on board with some of these common interfaces, because as you point out, they're often the physician managing these ladies, but they're not aware of the information you've just presented. And somehow that's the first step, is to increase people's awareness of these issues.
Exactly.
Thanks, Craig. Anybody else with any questions for Dipti? I guess that's a no. I think we've reached the end of our time frame that we had set out for this. On behalf of my co-chair and the other members of the Education Committee, I'd again like to really thank you for joining us and sharing your knowledge with us. And we certainly look forward to your leadership at the national level for this upcoming year. It was really a great conference. Thanks to all the attendees. Thank you especially to the presenters for the abstracts earlier. Really great to see the examples of scholarship amongst our trainees across the state. And again, hopefully people can join in on that WIC event in May. And hopefully if the vaccine rollout continues as it is, we'll be hosting this meeting in the traditional face-to-face format next year at the Waterview in Monroe. Thanks again. Everybody have a good night. And let me just share my screen one more time if I can, because I did.
Well, let me get out of it.
I did put this, I don't know if you could see my screen. This is the end, and for those that aren't aware, this is sort of this is the end of the Tom and Jerry cartoon slide or TV program, which was like my favorite TV cartoon growing up. So, good night.
Night. Thank you so much.
Well,
Thank you. Good night.
Thank you.
Good luck running the ACC.
Thank you.